Hey everyone, this is Kevin with Nursing KAMP.com, and this is my renal course on perfusion and acute kidney injury, where I cover the 7 most important things about this condition and the management of it. In today's focus, we're going to be covering intrarenal failure. It not only includes the videos, but my study sheets found on Nursing KAMP.com and my clinical resources. So let's get into it. Welcome to the final installment of this renal acute kidney injury, the phase intrarenal, which is the most important phase because now we're actually inside the kidney. And we're going to start to break it all down in this video series. So let's get into it. When we're talking about acute kidney injury and phases, they all have the onset. And that onset could be a pre-renal problem or a post-renal problem that is unresolved. Or it can actually be an intrarenal problem where we've given medications or contrast with those medications and we actually caused an insult or damage inside the kidney. So it's going to go through the basic same phases where that patient will become oliguric, and then we're going to be basically waiting for that patient's kidney to resolve itself, and that's the diuresis stage. But that recovery can take up to 12 months of time. When we're looking at the labs with intrarenal failure, we're going to again look at the BUN and creatinine because that's the main kidney labs. And we said that previously when the rules of this BUN and creatinine is to look at the BUN first. If that is elevated and the creatinine is normal, then the kidney is okay. And that's called 20-to-1 a pre-renal problem. But what we're talking about is intrarenal. And intrarenal is when you go to the BUN and that's elevated, you go down to the creatinine and that's also elevated. Well, that's a big problem because now the kidney is no longer working. So what we do then is we go down to the GFR. And what we look at is that GFR, and we're going to talk about that more closely when we look at intrarenal failure because the GFR is all about intrarenal failure. And in an intrarenal failure, this GFR is going to say how well the kidney is functioning. All right, let's look at 2 different situations. We're going to take the first one called acute kidney injury. So in acute kidney injury, we know that there's a problem either pre, intra, or post, which is called PIP. So we look at the BUN and see if that's elevated or not. If it is elevated, we check out the kidney and see how well that's working. If that's also elevated, we have an intrarenal problem. And what we want to do is assess how bad is that problem. The way that we do that is we assess the GFR. And that GFR is a number that we want greater than 60. And the reason why 60 is so important, if it is less than 60, they start to build up toxins like potassium. But in acute kidney injury, this number can go down and then it goes back up. And that's what we're trying to monitoring with acute kidney injury. So a lot of times I like to think about it as a spring. So in acute kidney injury, you have basically a spring on that GFR, where that GFR can go down and then it can go back up. And that's what we're trying to monitor when we're assessing a patient with acute kidney injury. Why does it go back up? Well, we treat the underlying condition. If we can treat the underlying condition, then that GFR should rise back to normal. If the GFR doesn't rise, then we need to really address what's going on as far as the underlying conditions. So how low is too low? Well, the GFR of 15. Well, that's an important number because less than 15, that's a real acute patient. Actually, in chronic kidney disease, a patient who has a GFR less than 15 will be a hemodialysis patient, most likely. So when we're looking at acute kidney injury, that GFR, if it drops below 15, then we might think about, hemodialysizing or CRRT with that patient. Okay, the next thing we're going to look at is chronic kidney disease. Now, chronic kidney disease is kind of like this hill over here. And what happens with the GFR, once it hits 60, we're going to try to slow down this progression down this hill. And how do we do that? Well, we monitor the sugars, the hemoglobin A1C. We make sure that they're managing their sugars and make sure that they are managing the hypertension, because that will slowly start to progress down this hill. And when's the issue? Well, the issue is once they get to a GFR 15. And that GFR 15 means that that's when we start talking about hemodialysis and what we need to be doing about that patient. So when you're looking at BUN and creatinine, especially for intrarenal patients, In an acute problem, the BUN is elevated and the creatinine is also elevated. Then you go down to the GFR, and that GFR should be greater than 60. If it is less than 60, we're going to monitor that and make sure that it's trending to go back up. Because in acute kidney injury, it's like a spring. It goes down and then it goes back up. All right, so let's talk about the next thing. Is that when a patient has acute kidney injury, intrarenal, we're going to look at the urinary output. And that urinary output is important because if a patient has intrarenal problem, we gave them some sort of medication or something like that, and it caused a problem inside the kidney, how do we know? How do we know it's an intrarenal problem? Well, we can assess that possibly that the patient has an elevated BUN, and then we go down to the creatinine. If that's also elevated, then we circle both of them, we go down to the GFR. And if that GFR is less than 60, we're going to be assessing this urinary output. And that's a second phase of acute kidney injury, because we said the first phase was the onset, and then it goes into the, which is actually the insult to the kidney, but the second phase is the oliguric stage, and because we want that urinary output to be greater than 30 cc's an hour or greater than 424 hours. If it's not, we might do a bladder scan where we're going to assess the bladder, and we're going to do the 4 P's of position, pubis, pressure, and pivot. And we generally want that, as we said, volume of urine in the bladder is generally anywhere between 100 to 300. If it's greater than 300, we're going to put a Foley in that person, or give them Lasix, or try to do something to get the urine out. In intrarenal failure, the insult to the kidney is caused the problem. Now, when we're talking about intrarenal problems, we're talking about inside the kidney. And as we talked about previously, we said that in intrarenal problems, they could either be a pre-problem that hasn't been addressed or a post-problem that hasn't been addressed. And if those aren't addressed, they can become intrarenal. And how do we know that that's an intrarenal problem? Well, once the BUN and creatinine are elevated, that's an intrarenal problem. But sometimes you can have specific things that actually do cause intrarenal directly. And those could be like H2 blockers. Like H2 blockers can cause intrarenal problems, mainly on the distal tubule, and also sometimes even hemolysis. And when we're talking about hemolysis, we might be talking about a patient who has rhabdomyolysis, or they have sickle cell, or something like that, where there's a lot of breakups or anaphylaxis or hemolytic blood transfusion, where all these particles are in the bloodstream. Well, they get stuck in the kidneys. And what happens is once they get stuck in the kidneys, they cause a intrarenal problem. The final thing we're going to look at is called a thing we call cake man. And cake man is just a mnemonic that when we're looking at medications that can cause intrarenal problems. So basically what this means is that generally if you're going to give a patient go for contrast, or you're going to go to a CAT scan, and you're going to give contrast. Well, we know that we assess for iodine allergies and such like that, but however, we generally do not give these medications with any contrast. And a lot of times if you're giving them together, if you're giving Keppra with erythromycin, there's a higher risk for an acute kidney injury or intrarenal problem. And what these medications are: cyclosporins, ACE inhibitors, Keppra, erythromycin, metformin, amphotericin, NSAIDs. And generally you don't give any of these medications with contrast. Now the problem with that is sometimes you do, but what you would do is you would assess their kidney functioning and prior to their CAT scan. And what do we do? Well, the big issue is for the NCLEX, and why this is important. If you gave amphotericin with contrast, and then the BUN and creatinine became elevated, well, which one caused it? Was it the contrast or the amphotericin? And so generally for the NCLEX, they don't want you to give those medications together. And generally in practice, we generally will question these medications whenever a person has chronic kidney disease, because you don't want to be giving them NSAIDs, because that could cause intrarenal failure. So cake man are the medications that are generally contraindicated with acute kidney injury. So what do we do for a patient with intrarenal problems? Well, with intrarenal problems, we need to first assess what's going on with the urine. And we said it previously, if we have a BUN and creatinine that are elevated, and then we go down to the GFR, and that's less than 60, we're going to probably put a Foley in that person because there's an issue going on with the urine output, and we're trying to watch this person to see whether or not they're going to move into the diuresis stage. We might even throw some Lasix at them or some Bumex just to basically try to see whether or not they are if the kidney needs a little gentle help with it. We're going to assess that urine for 30 cc's an hour for 124 hours. We might even do a bladder scanner where we're going to look at that patient and to see whether or not they do have residual urine in their bladder and where they're at with it. Also, the thing is that if that GFR starts to drop and keep on dropping and it gets below 15, we generally will think about hemodialysis. However, we do what's called chronic renal replacement therapy, which is a CRRT, and that is a low flow hemodialysis, and that's done in the ICU for patients with intrarenal acute kidney injury when we're really trying to rest those kidneys to make sure that they can recover. And how do we know they recover? Because in acute kidney injury, acute renal failure, that GFR will drop down and it should start to go back up, and that's what we'll be monitoring for. So a recap on this is that generally with intrarenal failure, they're going to go through these 4 phases, and when we have these 4 phases, we're going to be assessing these patients, but always remember that a pre-renal problem or a post-renal problem can become an intra-renal problem, and that's why assessment is very important for these patients, and also prevention, as we talked about in the previous lecture with post-renal problems, is that we protect the kidney or we assess that person so that we recognize if a person is becoming hypovolemic, that will increase fluids, and we're going to try to address these issues. So when we talk about acute kidney injury, it's all about prevention. Patients should generally be, unless there's a traumatic event, should generally be protected, and we should always be protecting those kidneys and what's inside the kidney. All right, let's pull it all together in Nursing 7. When we're talking about intrarenal failure, anybody can get it, whether they are, walking around, they could be sitting in the doctor's office getting medications, they could also be coming by ambulance, they could be on the floor. There's no differentiation between male or females, and age is unrelated. Main symptoms of acute kidney injury, intrarenal failure, is they could be pre or post problems. They could also be intrarenal problems like medications and stuff. And urinary output is primary symptoms of that. Decreased urinary output or decreased blood pressure or elevations of BUN and creatinine. So precipitating factors are pre and post conditions. Main complication is that the patient's GFR actually starts to drop and it's not going back up because measures aren't being corrected, and that patient will need hemodialysis or that patient needs really close monitoring. Q3 would be is that GFR is not going back up, and that means that the patient is not being treated correctly and we need to address it. Also, the acute 3 is if we have questionable medications that are like nephrotoxic medications, like for Cake Man, that we will question those medications as a person's in acute kidney injury. And the other 3 is that if we continually have a change of patient's condition, where that patient might actually go from an oliguric phase to the diuresis stage, the doctor would want to be notified that this is actually starting to happen and the kidneys are actually starting to be recovered. Will they be on a monitor? Of course they will, because the potassium is a major issue with these patients, hypokalemia, and they actually become toxic. And that's why they have to be on a monitor, because they can get VTAC and a cardiac arrest, and that's a problem. Blood pressure will always be monitored with this. Labs will be continually monitoring the BUN and creatinine and the GFR. We'll be monitoring the white count, not so much renals, and liver. We might look at the liver if multi-organ failure, but that's not most likely. Positioning, nothing really. We might do some ultrasounds of the kidneys. IV fluids, they might be on a Lasix strip, depending on medications. We'll be treating the underlying concerns. Temperature might be elevated, might not be. A pulse will be elevated. Respirations, depending if the complications. Blood pressure generally down. We try to keep that blood pressure, mean arterial pressure, greater than 60 to make sure that those kidneys are always perfusing. We're always going to be monitoring their fluid status with this type of patient and their pulses. Intrarenal patients generally will have nothing on the BNP or ABGs. They might have a little decreased level of consciousness as the toxins start to build up. Heart rate starts to increase. Kidneys mainly the main issue. The thing about acute kidney injury, intrarenal, is that most of these patients can recover if they are managed correctly and they're put into an ICU where that ICU they're monitored more closely. Most times they're sent to the ICU or CCU and to be assessed and to be closely monitored for these patients. Well, that's about it. My name's Kevin with Nursing KAMP.com, and this is my Nursing 7 on intrarenal failure. And the problem is inside the kidneys. See my other lecture where I talk about the problems outside the kidneys. We thank you for following me. Follow me on Nursing KAMP.com or on social media, Nursing KAMP.com. We'll see you next time. All right, bye.